Hello, welcome to my new presentation. This will be on histoplasmosis. So, what I'm going to do is first present a case, and this case will be followed by a short discussion on differentials and how to exclude the most important ones. And ultimately, I will have a review on histoplasmosis. Okay, so I'm Dr. Shariful Halim, and let's get started. Here is our case. A 30-year-old man comes to a routine health checkup before getting into a new job. So you might call it a pre-employment checkup. You have taken his history, and he does not smoke, nor does he use any alcohol or have any history of IV drug abuse or oral drug abuse. And he does not have a history of any occupational exposure. On further questioning, he is from a suburb in Mississippi by the Mississippi River. Okay, and you have done the clinical examination, which is absolutely fine. And you have ordered some investigations, including a chest x-ray. And only the chest x-ray comes abnormal, but other investigations are normal. Let's see the x-ray in the next slide. This is the x-ray. You can see the tracheal position is normal. The cardiothoracic ratio is also normal. There is no abnormalities with the diaphragms. Okay, I'm just kidding. I'm not taking you to the main point, which is actually in this black box. Not the black box of the airplane, but it's a black box. Okay, so what does this black box show? This black box shows that there is an opacity in the left upper mid region of the lung field, and this opacity is reasonably homogeneous, rounded in shape, and measures at around 2 to 2.5 centimeter, I would say. Okay, it depends on the percentage. So if it's a 100% image, you can measure like it's about 2%, 2 centimeter. Okay, so what do you call it? What are the differentials? So, as this is a lesion which is present only in the left upper mid zone of the lung field and isn't present in any other parts of the lung field, we can call it a solitary pulmonary nodule. Okay, what if the lesion was bigger? What if the lesion was 4 centimeter? So, if a lesion is more than 3 centimeters, you will call it a mass rather than calling it a nodule. Okay, so if anything is less than 3 centimeters, you call it a nodule. If it's more than 3 centimeter, you call it a mass. So this is a nodule. It's a solitary pulmonary nodule. So here are the common disease that you might consider whenever you have a solitary pulmonary nodule. Okay, first thing first, the most important question for you to decide in this patient is whether the patient has a malignancy, neoplasia, etc., or whether this condition is benign. So this is the most important part, if this condition is neoplastic or not. So this could be a primary bronchial carcinoma, or this could be a metastasis from a distant cancer. As you know that lung cancer is the most common cause of death among older population in all over the world. So this is very, very significant. Okay, and there are other conditions which are actually more likely in most of the patients. So those are more common. Those are more common, but they are not deadly, they are not fatal. So what are them? It could be a malformation, meaning that the tissue is deformed in some way. So it can be a cyst, or it can be a malformation of the vascular system, which is arteriovenous malformation. and it also can be a benign neoplasia, a dermoid, or a hematoma, and it can be an infection. So in those non-neoplastic conditions, I think the infection category should be given the most priority because they are common and often they can be treated with medications. So, if a patient comes from a background, like if the patient has a history of living in South Asia, for example, India, you might consider him or her as a patient with tuberculosis. If the patient is from Mississippi, as in this case, you could consider histoplasmosis. So, pardon me for my mistake. I have written histoplasmoma, so moma should be cut. It should be histoplasmosis. So, osis should be written in the later part of this word. And there can be other differentials. Echinococcosis from Echinococcus granulosus. This causes this causes hydatid cyst, and it can also be a lung abscess or pulmonary abscess. So those are the ones that we consider to be the most important differentials. But first of all, we exclude cancer. Okay, this is vital. So this patient does not have a high risk of cancer because this patient is very young, younger than 35 years. This patient does not smoke, and there is no family history of cancer, and this nodule have features consistent with a non-malignant lesion. So whenever someone considers malignancy, the malignant lesions are like irregular. So suppose this could be a malignant lesion because you see the borders are very irregular. The malignant lesions often have calcifications which are eccentric, not in the center, rather in the peripheral regions, and the nodules often occur in the apical region, and the nodules are often more than 2 centimeters in size. So if a nodule is more than 2 centimeters in size, this is a high risk lesion. But in this patient, we consider that cancer risk is very low. Rather, this patient is more likely to have an infectious disease, and in the background of this patient, most likely histoplasmosis. So the vital demographics. So this is the point that led us to believe that this patient might have a histoplasmosis. Okay, so demographics plays an important role in the most likely diagnosis in this patient. Yes, this could be other things, but the first differential for us would be histoplasmosis. Okay, so let's talk about histoplasmosis a bit. As you know, this is caused by a dimorphic fungus, which is Histoplasma capsulatum because it has a capsule. Question for you: what are the other dimorphic fungus, and what do you mean by dimorphic? Okay, so dimorphic. Di means two, morphic means two forms. So this is a type of fungus which has two distinct forms in different temperatures. So if it's cold, like if it's around 20 degrees Celsius or less, then it's a mold. Cold mold, mold in the cold. Okay, fine. If it's hot, for example, if it's 37 degrees Celsius or above, then it will be a yeast. So in heat, you find yeast. Yeast in heat. Okay. So whenever those fungus live in the environment, they're most likely to be in the mold form. And when they get into the human body, they're more likely to be in yeast form. So whenever Histoplasma capsulatum is inhaled, then it is inhaled in the mold form, or the spores maybe. And then in the human body, they are converted, they are transformed to yeast form. Can you remember the other dimorphic fungus? Okay, there are the coccidioides, which is coccidioides and paracoccidioides, and there are also blastomyces. Those are also very common in USA. So for coccidioides, you would find them in California. Blastomisis, you might find them in Wisconsin. And for paracoccidioides, they are more common in Latin America. Latin America. Okay. The histoplasmosis cases are often asymptomatic. So for the vast majority of the patients, they will not have any symptoms whatsoever. Only 5% of the patient will have some symptoms, which includes fever, chills, and sometimes cough. And as I have mentioned, this disease is endemic in the Mississippi and Ohio river valleys, and also in Central America. They're found in soil, especially soil which is very fertile due to contamination or due to mixture of bird or bat droppings. So you can say bird or bat poop and guano droppings. So those are the materials that enriches the soil, and it creates a very good environment for the histoplasmosis fungus to grow. And when you go into the caves of the Mississippi, you walk around, you splash, or you sometimes mash some of the fungus, some of the fungal spores or molds, and that start to go around the air, and you might inhale them. So you can inhale the spores or the mycelial fragments. As I have mentioned previously, if the patient does develop symptom, they will have fever, chills, and dry cough. Whenever a patient comes with cough, our rule is to do a chest x-ray, which most of the cases is normal, but sometimes can show obesity which may be patchy or maybe multinodular lobar infiltrates. And the last 2 points are the conditions which are very rare, which happens in patients with underlying disorders. So if someone has a COPD, he or she might develop a situation known as chronic cavitary pulmonary histoplasmosis. So this is a very progressive and fatal form of the disease, and this occurs only in patients who have some obstructive disease. And the last one is the most severe form of histoplasmosis, only occurs in patients who are young or immunosuppressed. For example, if someone has AIDS, or if someone has DiGeorge syndrome, etc. In summary, you can say most of the cases with histoplasmosis are asymptomatic. They're from a specific zone, which is Mississippi and Ohio river valleys. They come from soil, and here are some fun facts for you. Remember, fungus are often ingested by the macrophage. So whenever macrophage ingests them, they try to kill them, and when they don't, they try to multiply. So it leads to a granulomatous disease. So histoplasmosis is a granulomatous disease which is associated with the excessive proliferation of macrophages. And as you know, macrophages can produce the active form of vitamin D. So if someone has a histoplasmosis, he or she might have a vitamin D excess, which will lead to the hypercalcemia. And another fact, histoplasmosis can spread through your reticuloendothelial system, which includes spleen, bone marrow, liver, lymph nodes, and it can even go to adrenal glands, especially adrenal cortex. So it might have a complication, which is bilateral adrenal hyperplasia. In some case, this is associated with adrenocortical insufficiency, or you can say um, adrenocortical failure. And whenever this type of complications happen, you might treat them with conazole, such as itraconazoles or ketoconazoles. But if the patient have a significant adrenocortical insufficiency, then you might use something else, such as amphotericin B. Okay, I suppose that's all from this lecture. I think you have learned and maybe you have reviewed some of your concepts. They might come handy in some cases, but if you want to remember just one thing from this lecture, always remember that whenever a patient has a nodule in lung, the first thing you do to exclude malignancy. And when you consider malignancy, if the patient is older, has a history of smoking, has a family history, if the nodule is large, irregular, has some eccentric calcifications, or if the patient has other symptoms, such as symptoms of metastasis. And if you have excluded the malignancy, the next important differentials would be an infection or a malformation. And in infective differentials, the common ones that needs to be considered are tuberculosis and histoplasmosis. So if it's a patient from America, consider histoplasmosis. If it's a patient from Asia, maybe from India, consider tuberculosis. I think those are the things that are gross, and it might help you to have a stratification of the patients based on their presentation. I hope you enjoyed my video. Please like and subscribe if you want. It would help me immensely to fund myself and produce more videos for you. Thank you very much.